All right, hello. We are going to go ahead and get started. Just so everybody knows, this is being recorded and the link will be available as soon as possible in probably a day or so. In addition, today we have an additional resource of closed captioning. So if you go to the bottom of your screen on the toolbar, if you click on More, you will see a spot where it says Show Subtitles. So please check that out if you would like to use closed captioning. So I am Kristen Hedges. I use she, her pronouns. I am a middle-aged white female with long brown hair, currently sitting in my newly created home office in my bedroom. The reason for this verbal description is to address any accessibility needs of those who may be blind, low vision, or no visual access. So I want to begin by saying good afternoon, good morning, good evening, depending on where you are in the world. And thank you for joining us today for this webinar titled COVID-19, Ongoing Global Responses and Social Impact. This is being hosted by the American Anthropological Association, Society for Medical Anthropology, and the Special Interest Group Anthropological Responses to Health Emergencies. During this extraordinary global pandemic, leading to lots of stress and anxiety and the difficulties of physical distancing protocols, we want to thank you for joining us today. In our field of anthropology, we truly feel like we all have a role to play in this. We're all in this together, and it's our hope that today is a discussion, a conversation, and the beginning of ways to connect and collaborate and to think forward and together to figure out ways that we can contribute and proceed. So first, a few housekeeping tips. Next slide, please. First, a disclaimer, this is a very fluid situation, as I know I'm sure everyone is aware by now. So please keep in mind the date of this webinar, as information and facts and data and everything that's in here changes very quickly. So keep that date in mind if you're looking at future recordings. We will make this recording available, and we will also make the slides available. So you will have access to the recording and the slides later on. If you run into trouble with the bandwidth, if the connection to Zoom is difficult, you can feel free to dial in too. These instructions are here. And a few other instructions on the Zoom menu. On the bottom, these are the icons showing you the icons that you can find if you hover over the bottom of your screen. We do ask that everybody keeps their microphone on mute. This just helps us each to be able to hear the speakers. Also, if you could turn your video off, those help actually with the lag and the bandwidth. So if everybody could keep their videos off and their mute off or their microphone off. We are going to be collecting questions. We're going to hold all the questions to the end. So if you go into the chat function on the bottom, that is where you can submit your questions. My co-chair, Dion Claiborne, is in the chat room and she's collecting those questions on there to make it easier for her, since there is a lot of information that happens in the chat room. If you could put question in all caps, it allows her to collect those questions quickly. And we are going to end with a question and answer discussion and try to get to as many questions as we can. Next slide, please. So I am Kristen Hedges. I am the co-chair of Anthropological Responses to Health Emergencies, along with Dion Claiborne. Next slide. Our group is a special interest group out of the Society for Medical Anthropology, and our group first emerged after the Ebola health emergency and emerged and came together with the Zika crisis and the Zika health emergencies. We were formed as an official special interest group in 2017. Since then, we've worked on Zika, Ebola, the measles outbreak, and now COVID-19. We have a newly created website, so please check out our website. The link is here. And on our website, we've actually posted a call to action for research, and right now it's a call to action on engaged research items. We're actually working on a critical medical anthropology list also. We are hoping to turn into a group think. So we've posted this call to action of items that need to be researched within medical anthropology. And there's a link on there to the Google Docs to add your own comments or suggestions of what else you think needs to go on this. So check out our call to action. This is the link to our Facebook group. And the third thing is our expertise database. We are trying to collect experts and have an expertise database. That way, whenever a health emergency comes on and emerges, we're able to quickly see who has some expertise, either geographic or thematic, and be able to respond very quickly. Next slide. This is the outline of our webinar, and I'm going to give a chance for each speaker to give a verbal description of themselves before we launch into each speaker. The first speaker, Isaac Nyamongo, is actually from Kenya, the Cooperative Development University in Kenya. Due to time differences, he has done a pre-recording, so we won't actually see him, but we will have his portion of that first. Next up is Suman Chakrabarty. I don't know if I said that right, Suman. And Suman, if you're on here, could you go ahead and give a description, a verbal description?
Yes. Actually, I am from India, in the eastern part of India. I am basically act as a undergraduate teacher, but I am doing my research in the domain of medical anthropology, biocultural anthropology since 2003. And apart from the head of the Department of Anthropology, I also engage as a coordinator of the Food and Nutrition Department of the same institute. So today I would like to share my ideas, my knowledge, what the local values are related to the COVID-19 as a crisis. Thank you.
Great, thank you, Suman. And our third speaker today will be Jorge Benavides-Rawson. Jorge, can you hear us?
Yes, I hear you perfectly. Hello, everyone. Yeah, my name is Jorge Benavides-Rawson. I am a white Latino male. I use he, him, his pronouns, and I'm over here in my home office that used to be my living room. But in these situations, we make shifts. I am Costa Rican. I am a physician, and I practiced for almost a decade. And my research has been for a few years now on epidemics and pandemics, and that's how I met Christine and the rest. I think I cut off. Can you hear me?
Yes. Okay.
So I'm part of a member of the special interest group that we started back with Zika. And now, of course, my research has gone a lot more into COVID-19 and what's going on. So I hope I can share with you a little bit more about what's going on back in my home country.
Great, thank you, Jorge. Okay, next slide. So I'm gonna just give the introduction for Isaac. This is a pre-recording. Due to time difference, he couldn't be with us live, but he was able to share his slides and do a recording of it. And due to, I think, the bandwidth, the sound could be a little low. So just bear with us as we get his section of the webinar going.
Yes, good afternoon. My name is Isaac Nyamongo, currently at the Cooperative University of Kenya in Nairobi. I am unable to join you live in today's presentation, but I do hope that the thoughts that I share this afternoon will be of value to all of us. I am cognizant of the fact that perhaps most of us prevailing a situation. I am indeed joining from my own house at home. My presentation is going to focus on the social impact that a raft of measures that the government of Kenya has put in place is having on the social impact of the Kenyan society. It is, of course, difficult to state exactly how these measures have impacted us. That I will leave to research. In my next slide, globally, we know that COVID-19 has had a devastating effect on our lives, and it's no longer business as usual, given that many of us and our lives have been turned upside down. We are not doing things as the way we have been accustomed to do. And many of the things that we took for granted are no longer within reach. Globally, more than 1 million people have been infected, And we know that more than 110,000 deaths have occurred around the world. In terms of mortality, Africa has a mortality rate of 5.2% and recoveries of 19.5%. Within the East African region, we have about 3% death rate and just over 17% recorded recoveries. Now, the situation is not any different from what we see in Kenya. We must, however, take note that there is limited COVID-19 testing abilities or capacity within Africa. And in Kenya, for instance, we have tested just over 9,000 people. Uganda has tested about 5,000 people, and Rwanda has tested about 2,000 people. We do not know, however, how many tests, for example, Tanzania has done in the East African region. We do not know how many tests Burundi has done in the East African region, nor do we know what South Sudan is doing. Next slide. The situation of COVID is shown in this slide, and what we see are regional differences across the continent, with Southern Africa having more cases and more cases having been reported in the northern part of the continent and in the western part of the continent. But within the East African region, we see Kenya with quite a number of cases shown. Next slide. Now, in Kenya, the first case was reported just about a month ago, involving a traveler, a student who had traveled in from the US through Heathrow Airport in London. And since that time, we have had close to 208 cases as of 13th of April, and 9 deaths recorded with 40 recoveries. And the initial people who are tested positive are those who are coming from abroad and those who are traveling. Basically, we're seeing currently a new level of transmission at the community level. And this is, of course, of great concern to us. From the data we have so far, we notice that more men than women are getting affected. And in terms of urban-rural differences, we see many more cases within the urban areas compared to the rural areas. But in the most recent data that we have been able to get, we are now seeing community-level transmission, and that should be an area of concern for us. In terms of the age distribution, about 2.4% of those infected fall in the age range below 15 years, whereas 27.9% of the persons who have been infected fall within 15 to 29 years. The majority of the people who are affected are those between 30 and 59 years, and we are fewer within the age range above 60 years. And as the map shows, the epicenter of the infections in Kenya is Nairobi, with another cluster appearing at the coast, in the coastal region, the 3 counties of the Kenya coast, which include Kwale, Mombasa, and Kilifi. Next slide. Now, the government of Kenya has rolled out a number of public health interventions, which are mainly non-pharmaceutical. And these include social distancing, washing of hands with soap or using a sanitizer where one does not have access to water, wearing of masks, especially in crowded places. We have a curfew, a dusk to dawn curfew, which mainly targets social places such as bars and nightclubs. But we have also seen in more recent past a partial lockdown affecting Greater Nairobi and its environs. And also, question that we need to ask that have been put in place a response committee whose key mandate is to manage the pandemic, to manage the manner in which the government is responding to the challenge. Now, the representation of the technical committee has experts which do not include social scientists, including, of course, anthropologists. And this could impact the successful rollout of the intervention measures which address the social and the behavioral aspects of the people. Now let us look at the social distancing that have been put in place. Next slide. Now we're being asked to keep a safe distance, which is defined as 2 meters. Would it be better to use physical distancing given the cultural context within which the term is being used? Social distancing vis-a-vis physical distancing. We may ask, when we tell people to keep at least 2 meters, between themselves, what exactly is 2 meters to a local person who is in an open air market, or even to a person who is jostling to get public transport to get home from a long day's work, or to a person in a queue at a supermarket? What is 2 meters? One challenge is getting this message in the rural areas where risk perceptions may not necessarily be the same as those in urban areas. And we have instances, for example, in the rural areas where relatives see a person as their son, as their relative, as their brother, but not as a potentially COVID-19 case. And therefore, social distancing is of least concern to those people. As part of the social distancing measures, the government has advised that places of worship be closed. But within the region, not all countries have done so. And for example, Tanzania has not, put this measure in place. Washing of hands is another area in my next slide. Now, while it's easy for government to make a proclamation asking people to wash hands or to wear masks, communities are asking, what is more important? Is it to use the little savings to buy food or to go looking for masks? Access to water, particularly in the urban informal settlements, is another area of concern. And one of the major measures that the government has put in place to complement social distancing is curfew. The curfew, which I cover in my next slide, is bound to affect social relations. It's found to affect access to food. And of course, it's found to affect distribution of commodities across the country. And in a recent briefing from the Ministry of Health official, it was noted that there has been an increase in the reported cases of sexual violence, gender-based violence, and domestic violence. And these are issues, these are social issues that we need to address. These are social issues that social scientists will be best placed to address. And in the initial enforcement, for example, when the curfew was declared, the initial enforcement witnessed police beatings as they were forcing people to comply to the requirement. And this, of course, enlisted immediate public outcry from the community. It makes people angry. But we also have to ask, what happens to people who are laid off work or those who live on daily wages? How do they cope? For these people, the difference between having a meal or not lies in whether they have something to do that day. These are issues of anthropological concern. People who, for them to have a meal on their table, requires that they must live every day, and yet we have all these limitations. Of course, in the informal settlements, a curfew could also mean access to or lack of a toilet, which often in those, in that setup are found outside the house, or even access to water. Which is also found outside the house. So now one of this was to quarantine people. And this is especially travelers. In my next slide. Yes, in my next slide, we'll see that in a number of instances, especially at the beginning, international travelers were forced to be quarantined at their own cost at the designated places. Some of the facilities that were used for quarantining people were ill-equipped, and for instance, some had common ablution blocks and dining areas and did not even prevent people from mixing. Needless, of course, to say that some of the travelers were unable to pay for their 14 days of unprepared forced quarantine, or even the additional days of quarantining for those persons who were unlucky to have a positive case within their group. The extended burden now, of course, I beg your pardon. The extended quarantine was those who had been asked to stay longer than they had prepared or even planned or budgeted for. And therefore, that caused a lot of challenges for. Yes, we must, of course, address stigma and hostility in the community for those people who have been found to be COVID-19 positive. And here, for instance, I just need to point out that in some cases we have had situations in which community members have wanted to raise the compounds of people or to ban compounds of people who had been found to be COVID-19 positive, accusing those people of wanting to infect or kill the whole community. And this is not just one, it's not an isolated incident. We also have another one in which a local leader was branded to be worse than a murderer after he had failed to quarantine himself and later turned out to be COVID-19 positive. In my next slide, we see that the effect of COVID-19 clearly manifesting. The tourism industry, the horticultural sector, the transport sector are some of the areas that have been adversely affected due to this pandemic. And At the coast, for example, where tourism is the mainstay, we have seen closure of hotels. In the horticultural sector, particularly where flowers are produced for export purposes to Europe and other places, we have seen workers in those places furloughed because the companies are no longer able to pay them. And this, of course, has led to a lot of losses. Now, without income, individuals cannot afford to purchase food or to even pay their rents. A raft of measures that have been put in place include the reduction of taxes that have been, instituted by government to cushion people. Similarly, we have seen additional social safety nets that have been put in place to protect the elderly, to protect the orphans, and to protect vulnerable people. And this is being instituted through cash transfers. Finally, in my next slide, we should not forget students who are worried because they cannot take their national examinations, or the frontline health workers who have had to deal with patients and deaths that occur in their facilities. These groups need robust psychosocial support to cushion them. And therefore, as we discuss the issues and the effect of COVID-19, I hope that these are some of the areas that we can look at as anthropologists in order to generate further discussion and interventions. Thank you.
All right, thank you so much, Isaac. So just as a reminder, if you're joining us late, Isaac did his recording. He pre-recorded that due to the time difference. So he is not on live with us, but we will be able to answer any questions that you have for Isaac. We will be posting them to the community's platform after this webinar. And a few questions were brought up in the chat. The recording will be available and the slides will be available. So next up, we have Suman. Are you still there, Suman?
Yes.
I'll pass it to you.
Yeah, thank you, Christian. And this is my first presentation through webinar. So let me begin with one story which I perceived during my PhD work in Odisha. That during my PhD work, I stayed inside the forest areas for the several installments for the last at least 3 years. So at the beginning of my field work, I used to take one kind of roots which are consumed by the tribal people. This is known as sub-tribal people. Now, initially, I ignored to take this route as because I do not know what kind of things are embedded in particular route. But they assure me that if you consume this root, it is very essential for your survival inside the forest areas. So later, when I analyzed this root for my own understandings, I got that this root contains 21% carbohydrate and anti-helminthic properties. So that is the beauty where the day-to-day life, food and food habits, and also different kind of medicines embedded into the populations in India. So in that particular context, I am trying to conceptualize the COVID-19, that is unprecedented conditions throughout the world. India is not an exception. So in the view of the student of medical anthropology, I am trying to conceptualize the whole things. Next, please. Next slide, please. So when you began to talk of the COVID-19, any sort of things in India, we have to understand what kind of cultural diversities in India. So in India, we have the different cultural diversities, and within which we have Hinduism is the largest one, and we have also the minorities. Next, please. So within, next, please. Christian, next, please. Yes. Within the Hinduism, they have the patriarchal nature, and please. Reverse, please. Reverse, please. Yes. And we have the Hindu caste system. The Hindu caste system is a deep embedded things which already existed in Indian culture, and you see that there is a untouchability also this there. I have the different kind of stories throughout my field work last 15 to 16 years. So if we'll get the time, I will share you later. Next, please. Now, apart from the big caste group and the different cultural group, another cultural group, that is the indigenous group, we call this as the scheduled tribal group in India. Though this population is composed on only the 8.6% of the total population of India, but this 8.6% conserve the 70% natural resource in our country. So they have the deep connections with nature and the populations and the deep connections. And apart from that, within these 705 different scheduled tribes, we have the 75 tribal groups who are designated as PVTGs, particularly vulnerable tribal groups. So one of the criteria to select the particularly vulnerable tribal groups is their populations. And now the fear from the anthropological point of view, if any sort of populations they will be infected by this, if may be infected by this COVID-19, then this population may be may leap out in a shorter period of time. So we have to keep it in our mind. Next, please. So in that particular context, next, please. In that particular context, another major problem in India is the migratory labor. You see that in a migratory labor comes from the northeastern part of the India and to travel to Kerala and the southern part of India. So there's a huge differences exist. The migrations are very inverted cause, and they are the daily wage living activities, the uncertainty, all things are going in simultaneously in their way of life. So apart from that, you see that in a single Rawa village in northern part of Bengal, 11.40% of the youth, they are the migratory labor. So when there was a lockdown called by the government of India, so in the 25th March, and after that, there's a huge rush to travel this migratory labor from the capital, the different capitals of India to their own villages. So that is the important part, and this is social distancing as the no maintaining of social distancing. Next, please. So in that particular context, next, please. Next, please. So you have the different disparity in the poverty level. You see this Kerala and West Bengal, there is a different disparity in the socioeconomic inequality is there. Next, please. There is a disparity between the educational attainment in the state-wise. You see the Kerala and you see the Mizoram. Both of these states at the higher educational level. But if you go into the deeper understanding, you see that the Mizoram people, they are the tribal people, and majority of the tribal people in India, the extent of literacy is not so high. So the Kerala people are high human development index, and all these things are very important for in the context of India as a whole. Next, please. Next, please. Yes. Now the thing is the important thing. I captured this photograph in 14th or 13th April from internet, and see that there is a huge COVID-19 cases in Maharashtra and Tamil Nadu is the western part of India in compared to the northeastern and eastern part of India. Though the first COVID case in India was reported in 30th January in Kerala. Now see, this is the 30th January. Now the thermal screening on the airport on 3rd March. So 30th January and 3rd March is a long time in between that particular. There is no such cases. No such measures, I think, maybe have occurred in this particular time. So first lockdown started in 25th March, and second lockdown started last 14 April. So there is a time frame where even in the lockdown, there's a rise of the prevalence of the COVID-19 in the different states. Now, apart from that, there's a stop of the heart of transportations, that is the Indian railways. So into the 25th or 22nd to 25th March. So this is the stopping of the heart of these Indian communications. So it also hampered to transfer these migratory labor from the base of work to the origins. Next, please. Next, please. Now, the Indian health system is very important in the context of public healthcare systems. So we have the national level health systems, state level health systems, district level and block level. We are doing a lot of job that both the central governments and state governments. There's no hesitation or going on a particular action. But the thing is that how these informations are channelized from the national level to the block levels, it is very important and is a fact because of the next please. Next please. And the huge number of initiatives they are taken by the central government of India. You see that they have launched on ARHE Setu. We have this ARHE Setu means is a Sanskrit word. It's the bridge of healthcare system. The bridge of healthcare system, and I have already downloaded this app and in my mobile, and from my mobile now the confirmed case is 12,759 and recovered cases 1,515 and disease is 420 disease. Now in West Bengal the confirmed case is 231, recovered 42 and 7. So in the context of Indian populations, so this is very small cases that affected by the things by COVID-19. Now this is the face of Indian actress Amitabh Bachchan, who's trying to giving some basic understanding through the video link. You can get it from myindia.com, and he's a Narendra Modi is there, and he's repeatedly come in the national talk. They repeatedly come to the TV and televisions and give the lectures. So next, please. Now, what are the different ministerial and nodal agencies they are doing? So there's the Ministry of Health and Family Welfare. They are doing their jobs. They are giving the mass awarenesses. The Ministry of Ayush is also important part. You know that Ayush, all of you know that the Ayush is formed in 2014. And they Ayush full name of the Ayush is Ayurveda, Unani, natural yoga, naturopathy, Unani, Siddha and homeopathy. This is all the age-old traditional medicines, and we are trying to implement this sort of medicines, the knowledge to the overall Indian population. So there is a problem. So see that there's a severe acute respiratory illness, one paper published by one nodal agency, Indian Journal of Medical Research, that is ICMR Journal, Indian Council of Medical Research. Then they have their own team. So I think nobody from the anthropological background. So it is one of the important things should be taken into account. Though ICMR have their own units at social and behavioral sciences and headed by the Dr. Babu, who are from the anthropological background. Hope Government of India is also consulting with the different kind of anthropologists who are heavily worked in that particular domain. Next, please. Now, what Ayush Advisory Committee, they are not giving the advisory for claiming the COVID-19 treatment. What the important thing is the Ayush Advisory for immunity and enhancement. The immunity, one of the important basis for the fighting for the coronavirus, virus infections. So we have the different kind of yoga postures, we have the different kind of herbs, and this is recommended by the different Baidyas. Baidyas, that is the traditional healers. Now across the India, they form the group. The Government of India formed the group. The Ayush department formed the group, and they prescribe to some of these remedies how to boost the immunity for the overall Indian population. That is all the awareness program. Next, please. Next, please. Now the who are the key soldiers in the rural and remote areas, because more than 68% of the Indian populations, they belong to the rural populations. So if the infection is going to the rural population to the large extent, so then the accredited social health activists, the ARHE people are most important, who are the connector between the governments and the villages. So that is important. So how the ASA villages, they are perceived, you know. Next, please. Next, please. Now, state government in West Bengal, our Chief Minister, Mamata Banerjee, she repetitively symbolizes to grow the awareness and all these things throughout the West Bengal, throughout the media, and every day he came to the media and telling what the situation is going on. They have their own website, and we can get all the information. Now, why West Bengal is important for because I am also the native people from West Bengal, the eastern part of India. So why West Bengal is important is because this is the international border of the Bangladesh, and also is the corridor of northeastern part of the India. So if there is an increase of the COVID-19 cases in the northern part of the Bengal, or is a margin of this border, then obviously it crosses the cross borders. So that is important, and also the different states are also the merging positions. So for the transmission of the disease. Next, please. So in West Bengal, the educational lockdown is going on. Government had decided to promote the students up to class 8. This is a state government decision. So as because the lockdown is going on, all the educational institutions is closed. So the online classes are carried out by students of class 9 and class 10 by involving the media, specifically the different news channels. Now, private schools, they are taking the classes through the online mode. So you see that two pictures. So this is the one pictures where the children are taking the teaching from home, this from the private schools, and this is the villages. There's no bother about what kind of things are going on outward. We are also taking the classes through the online, and this is a different kind of exposure from the students and teachers' point of view. So I think this is also a valuable, important thing for we should learn the lessons from the education from the lockdown. Next, please. So this is the local perceptions regarding the COVID-19, the nationwide 19 land as proposed by our Prime Minister Narendra Modi in the 5th April at 9 p.m. and 9 p.m. and for 9 minutes. So see that this is a Belur Mart in India and located in Kolkata, and the monk from this particular Belur Mart, that is one of the important temples there for Ramakrishna, worshipping of the Ramakrishna there, and one of the important symbolizing place for the Hindu peoples. But simultaneously after that, we suspended the community religions program for the worship. The 12th April, there is a Lord Shiva is there. The Lord. So otherwise, there is a huge gathering, mass gathering happen in every year in that particular locality. So that measures, that things we are conceptualizing the severity of this disease, and if we are infected due to the fearness, they are maintaining this sort of the community, suspend the community program. Next, please. Next, please. Now the lockdown in urban areas is a city of joy. At the Kolkata city, the lockdown is going on. Shopping is closed in mall. Next, please. Now the thing is the social distancing and physical distancing. Now the people of the village populations, you know that the 70% of the more than near about 70% of the population, they are living in the village areas. They're trying to maintain. So they are, even though they are not conceptualizing what the thing is going on. So there is a relief camp near the border areas. The people are going here and there to So social distancing or physical distancing, whatever it is. So still now we are not conceptualizing, though the police are doing heavily. So by betting the people, by capturing the law and order in the village areas, they're trying very much, the state government as well as the central government repeatedly. But the thing is that if the people are not coming from the heart of this thing, they are not conceptualizing the actual positions of the what kind of disease is very hard to maintain all these things. Only the praying is not the way to going on. Next, please. Now what the indigenous people are doing, this is a picture I captured from this person. He sent me this picture through the WhatsApp, and this is Santal people. You see, in villages they are maintaining some distances, and from the Purulia district of West Bengal, the western part of West Bengal. So this Purulia district and Jalpaiguri district, these two districts are heavily populated by the tribal peoples, and this is the indigenous groups. So they're maintaining the social distancing, and social distancing is very encouraging for the Kashi tribal peoples who are living in the northeastern part of the India. So they have the better understanding what thing is going on. Hopefully the historical understanding also giving some clue. Next, please. Now I captured also through telephonic conversations the Bodo community in the northern part of our West Bengal. The informant is named as Samar Singh Thakur from Bodo tribal community. So I tried to capture the conception of the community's perceptions regarding the COVID-19. So what he said that they all are aware of the fact regarding the COVID-19. There's no thing, but young people refuse to make the social distancing. So even though they are knowing the consequences, what is going on, but the case is not yet embedded in the particular community. So they refuse to make the young generation, they are not so much bothered about this. Now, third, the most important thing is that when he asks them that they know what the consequences are coming through the infections, that is a pneumonia. So they have their own traditional medicines. They declare that they have their own traditional medicine. They believe on the evil spirits. They want to wait and see the consequences. So the people are the tribal people specifically who are very close to the nature. They are trying to see what happens if the COVID-19 cases will arise in their particular community. How they defend by using the traditional medicines and their age-old traditions. So that is important. How they connected. Next, please. Next, please. Now, see the medicinal plant. So this is the medicinal plant of for the malarian fever. We locally name as Ganga Tulsi, Ganga Shuli, and people are basically primarily depend on these type of trees for their different kind of diseases. You see that there's a different part, there's a different doses and different taboos related on this particular medicinal plant. So thing is that not only the medicine, but also the people values what kind of values added to the medicines are the important things. So they believe in the nature. So there's a very good connections between what the Ayush are prescribing and what the medicinal, what the indigenous populations are believing for the fighting the COVID-19. Next, please. Next, please. So what medical anthropologists can do in India COVID-19 emergency to act as a cultural interpreter in the context of public healthcare system. So I don't know whether the government are not capable to adopt the anthropologists to do the healthcare system, but they have if the COVID-19 invaded into the rural and tribal communities, then obviously there's a huge role for the anthropologists to act as a cultural interpreter, and because the acceptance of the community, there's a huge number of anthropologists they're doing huge job, very good job in the medical anthropological perspective to look into the ethics. And the second point is the human ethics during the implementation, the mass awareness. So yes, discriminations is there, is a discriminations, and untouchability is also acted in Indian caste system, through the Indian caste system, the different communities. So we have to keep in our mind that human ethics, and basically the primary duty for anthropologists to aware the government that we should look into the matter of the human ethics to help the community decision making, specifically who are the cultural transitions. So their stands in the dilemma whether they are taking the drugs from the government or they're practicing their age-old traditions. So this is a very transitional phase. I have been done different kind of work regarding the community decision making, and Dr. Babu also did one work and published in the Anthropological Review Journal. That the tribal people who are living in the urban areas, who are migrated from the rural to urban areas, they expose into the urban settlements. So they are in the dilemma of what kind of treatment they are taking, because this is an unknown thing. The COVID-19 is an unknown thing, new things. They are not conceptualizing what these things are going on. So the fourth thing is that over the COVID-19 through the emic perspective. So the emic role and value levels. So that is important. That should be highlighted into the policymakers. So knowledge, why knowledge is important? Unless and until you are connected with the things. To encourage the community participation in the new crisis, this is another important things for thing. Next please. So with that particular note, I thank you all, specifically the Christian for inviting me. And there's a picture drawn by our family, my daughter, as because last day after tomorrow, so yesterday, and on 15th or 14th April, we passed our Bengali New Year. So my daughter asked me that how we can use our celebrations in the closed circuit. So I told him that we may develop some kind of photographs or the mass awareness. So with that particular notes, I invite the questions if anyone for a specific purpose. Thank you. Question.
Thank you so much, Suman, for that wonderful discussion and giving us the perspectives on different responses from India on making sense of fear and risk and care and what modifications are happening at the community level. And I love the drawing from your daughter. So thank you for sharing that. We're going to hold the questions until after Jorge's presentation. So if you can just hold on, we will pass it along to Jorge next.
Hello, everyone. You hear me all right?
Yep, we can hear you.
Perfect. So as we mentioned, I'm going to talk to you a little bit first about the general situation in Costa Rica, but then I'm going to delve more into, of course, more socioeconomic and cultural issues about the response and about the result that we're having. So next, please. And please do let me know if I go too fast. I do that when I speak even faster in my native language, in Spanish, so could be worse. Just to give you a situation about the area where we are, which is in Central America. Of course, you know Costa Rica is the one in the darker green. Sorry, that we have the second highest number of cases in Central America. That the graph on the side includes Dominican Republic, and that's because economically we are the country that signed a free trade agreement with the United States, so CAFTA-DR. But in the mainland, Panama has the highest number of cases, and this probably has to do a lot with the fact that they are a hub for COPA, so a lot of flights that cross through Central America have to go through Panama. And then Costa Rica is the second one, and as you probably know, Costa Rica's main industry is tourism. So we receive a minimum of 2 million tourists a year in a country of 5 million. So that's a lot of people coming in. And in fact, the first person that was diagnosed was an American from New York who was there as a tourist. And then another case was brought in a physician from abroad And after that, that's when we started getting our first domestic cases. So far, we have 4 deaths. The number 4 was announced yesterday by our Minister of Health. And that puts Costa Rica in a fatality or lethality rate of 0.6%, which is quite low. So I think it's one of the 10 lowest in the world. And we're going to talk a little bit about why that might be. On our northern border, we have Nicaragua. And Nicaragua has reported only 9 cases and 1 death. The WHO, and especially Pan American Health Organization that's here in DC, has expressed concern about their inability to confirm these numbers. They are not sure if it's possible to have such low numbers and the way that it's been measured. Early on, the government started a public campaign to control coronavirus that included mass parades or congregations of people, sort of like singing and chanting in favor of the government and against the virus. So that was a little counterintuitive. So we're not sure of how the situation there is, and that has concerned the Pan American Health Organization a bit. Next, please. So up to yesterday, this is the numbers from yesterday. Costa Rica has 626 cases. As you can see, 224 men, 202 women, 4 deaths. In terms of severity, only about 16 people are hospitalized and 11 have required intensive care units. And that has helped, and also the fact that we have prepared beforehand. And I'm going to tell you a little bit in a second about what I talked about with several intensive care unit doctors about their preparations and how they're handling this. The majority of cases are in middle-aged adults, a few in children, and about 5% in elder people. But as you can imagine, the mortality is higher among that group. The majority of cases in the dark areas, and those dark areas in the map, are the main provinces and they have the highest density of population. So San Jose is the capital; it has most of the cases there. And then Alajuela, which is the province next to the capital, and it's what we call a dormitory town. It means that a lot of people who work in San Jose live in Alajuela. So during work hours in a regular day, San Jose could have about 2 million people working there. That's about 40% of the entire population. So in the rural areas, in the coastal areas, we're having a lot less cases, which has to do with the density of population, but also has to do with the fact that tourism has stopped, and those are the highly touristic areas of our country. So now that they're not receiving tourists, the chances of infection are lower, but also the economic impacts have been quite high. We're going to talk about that. Next, please. So the way that our government has responded, it's interesting to analyze because it also reflects a lot of the cultural beliefs and practices of Costa Ricans. So the first case was reported on March 6th. And very quickly, that was, I think it was a Friday or close to weekend, the next weekend, the government suspended all face-to-face classes in high schools and universities. And by the 16th, we had declared a national emergency and closed borders. And that the closing of borders meant that only Costa Ricans and legal residents could come in for a period of time if they were abroad. But it also meant that if you are a legal resident, if you leave the country after that day, you will lose your status, not permanently, but until the crisis ends. So if you're a legal resident and you leave the country now, you won't be able to get back in until after the crisis, even if you have a document that says that you're a legal resident. Anyone who comes in, I think any country has to go to a 14-day mandatory isolation or quarantine, usually at home. And the number of flights have diminished drastically into the country. Now I think it's mostly people who have left. There's been some charters going in and there's some commerce going in, but passenger flights have almost stopped. The government also closed all beaches, temples, and religious services. And it was, early on, the government did not do this, but it became evident that people were still congregating in spaces like fun on the beach, at bars. So the government had to sort of put the hand in there, because there was a little bit of a lack of discipline there in going. So all those spaces are now closed. They increased fines for bars or restaurants. If they have people in there, the fines have gone a lot higher now. In terms of religious services, and this is, I think it's interesting because we are analyzing this here in DC. The Costa Rica is fairly homogeneous, the majority Christian, and within that, the majority Catholic. So the Catholic Church has worldwide already issued guidelines of not holding mass, etc. So that has helped. We are still looking at them, and as part of my research is looking at how different faiths respond to this in Costa Rica, and the need to not congregate. I understand from interviews I've done that some other Christian denominations were not as willful to stop services, and that's part of why the government had to order the closure of temples to make them do that. The other interesting thing is the vehicular restrictions as a method of control. Costa Rica is used to this. We used to have restrictions aimed at controlling traffic and air pollution in the capital. So before they started, for many years, depending on the last number of your license plate, you cannot go into the city one day of the 5 days of the work week. So that idea was already there, that this idea of having restrictions. So what the government did was extended. First, it started a restriction of after 5 p.m. until 5 a.m. the next day. So all night cars could not go out. Weekends cars could not circulate. Then it got extended to only 2 days that you were allowed to. And that had to get particularly hard or particularly strong during Easter week. Again, being a majority Christian country, Easter week is an important holiday. Usually people don't work the whole week. People tend to go to the beach for that weekend. Thursday and Friday of Holy Week are national holidays, so people have a long weekend. So it was a feat of the government trying to avoid all this, and so restricting car movement was one of the ways to prevent the mass exodus from the Central Valley to the beach area, which worked. There's still people who left, but the majority of people did stay home. The following Monday, so this Monday, there was sort of like a pushback, and a lot of people, after the restrictions eased a little bit, went out, and there was a lot of criticism in the media about how many people went out. But this has to do also with the different socioeconomic situation of different individuals, and in a little bit I'm going to talk about this. But the obligation to stay at home cannot be followed the same way by different people depending on their economic situation. Let's see, next please. So as I mentioned, on the 30th of March, the government did pass legislation increasing the fines for violation of sanitary orders. And on the 31st, and this is important, the government preemptively transformed the hospital that was used for physical rehabilitation. It was converted completely into a COVID-19 center. They set respirators there, different beds with isolation. It's not made for severe cases. It's not an ICU. So the plan of this is to keep the patients who are severe enough to need hospitalization, but not those who require intensive care. For that, the three main hospitals, or the biggest hospitals in the country, have set up their intensive care units for this. I talked to the head of one of the hospitals, And what they did is they actually split their ICU. So in two different floors. So one floor is for COVID-19 patients, and all the other non-COVID-19 ICU patients are in a different floor of the hospital. So far, they have not maxed out. They have not been full at all. There's only 11 cases in ICU countrywide. So the country has not reached that peak use of the hospital system, which in a big part has helped in that control of the mortality. It's important here to know also a little bit of the context. Costa Rica has a universal healthcare system that's been there since 1948. Sorry. It's mandatory, so everyone's part of it, but it also operates alongside private healthcare system. And so there are private options, and the government has authorized several private labs to also conduct COVID-19 testing. The president of our healthcare system has also come out publicly to clarify that everyone will be treated in this epidemic regardless of insurance or migratory status. So he has been very vocal about it, letting people know that they should not by any means fear going to the hospital if they have symptoms. The distribution or the information that's given also by the government and the healthcare system has been constant. In our country, it's been the Minister of Health who makes all the policy for the country in terms of health, and the president of the healthcare system, who have been pretty much running the show in the country. They used to give long press conference like in the United States every day. Now they're doing about a short one every day and a longer one about 3 times a week. So they kept the community informed. A big part, I think, a cultural situation here in terms of the response of the population to the system is an ongoing trust that the average Costa Rican has with the system. There's critiques about, of course, sometimes you have to wait a long time for elective surgeries, which, by the way, have all been canceled during this crisis. But for the most part, as a system, people do, trust the intentions of the system. The people are used to knowing that it's there for an emergency. You don't have a copay, so there's no fear of going bankrupt for having to pay high medical bills, which also then promotes more people to going to get tested without the fear of having to pay an exorbitant amount for this. Next, please. So now I want to talk about how this has maybe exacerbated the socioeconomic inequalities in the country, and how also those already existing inequalities take part in the response of people to the measures. So Costa Rica, as I said, has about 5 million people. The poverty is about 21%. That's before the epidemic started. About 1.6 million households in the country of those. According to Estado de Nación, which is a publicly funded accumulation of data and information about the demographics and economic status, they say that 90,000 of those households already didn't reach minimal children nutrition. This is before the pandemic. 9% of houses are in bad state, and 2% are overcrowded already, which, of course, as we know, overcrowding would increase the risk. There is an important socioeconomic divide and equality. You see the top picture is one of the nice neighborhoods in Costa Rica in the upper, middle and upper class. The bottom picture, it's a lower income neighborhood with houses closer together without strong walls where there are leaks. Some houses in lower economic areas are built in region or parts of the cities that flood sometimes, forcing people to have to leave. Already about only 77% of the population is employed now because of COVID-19, the increase in people losing their jobs in the formal area, but also a lot of informal jobs have been lost. People who work in delivery or to drive things around, people who have day-to-day jobs Also, there's been a mass mobilization of Nicaraguans who work in Costa Rica. Costa Rica, about 6 to 7% of the national population is Nicaraguan. And a lot of Nicaraguans work in Costa Rica in domestic labor, in construction, and in the farm area. And so those tend to be jobs that are paid day to day or week by week. A lot of them are not enrolled in a salary that gives them certain access to a lot of the benefits. And so those are a lot of people who have lost their income. And of course, a lot of people have decided to not employ people who provide services inside their households because of fear of transmission. Another worry here then is, of course, food insecurity. It has to do, on the one hand, with not being able to purchase enough food, but on the other hand, also just the economic effects of this pandemic in the production of sufficient food. So far, it's not been terrible, but it is happening, and there are already NGOs working on this. I talked with someone who works for an NGO called Alimentalista, and what they do is it's food rescue. So they've been working, they work with companies or farms that have to or are about to get rid of large quantities of food because they cannot sell it. And then they take it and bring it to either prepare foods or for distribute it to people who cannot purchase it regularly. Also, the socioeconomic inequalities make it so that a lot of people cannot stock food for a lot of days. So telling people to stay at home, it's not the same if you have a middle income that lets you buy food, let's say for a whole week or for 2 weeks for your entire family, versus people who have, get paid day to day or week to week and can only accumulate enough food to have at home for 2, 3, or 4 days, especially in families that are larger. Next, please. Another big impact, and that's on education. So as I mentioned, the president early on declared or sent people to study at home, but that has shown why the inequalities in terms of access to certain technologies are for this in order to continue with online education. As you can see in the top quintile of income families, about 80% of people have good access. That's usually fiber optic or cable, so high-speed internet. But when you look at the bottom quintile of regarding to income, only about 37% have good access. And a lot more people rely only on their cell phone to get access. And that access is not constant. I talked with a few professors at universities there, and one told me how of his class, he was missing 9 students, that he tried to figure where they were, so they were not showing up for online classes. He was only able to contact 2. And those 2, one told him that, yeah, my phone has internet access, but where I live, there's no internet access. So I have to walk about an hour because there are no buses anymore just to get some signal. And the other student said, yeah, I do have access, but I have to work now because my family of 4 has a total income of about $200 a month. So, education has, been put on the hold. There's also a gap in the expertise of educators being able to use these technologies. So 7% of private institutions that tend to have better outcomes, the educators are used to digital technologies. In public schools, it's not the same, so that has put also limitations. And as you can imagine, we will see in the future how these inequities in education access will reverberate in future income inequalities of people who were not able to access education or had to drop out of this. Next, please. And in terms of social distancing, curfew is illegal under our law. Costa Rica has a big history of pacifism. We abolished the armed forces in 1949. And any law that could give the government sort of a totalitarian power has been taken out. For example, in Costa Rica, people in jail get to vote in every election. And curfew cannot be ordered. So the country has to invent other ways, sort of like the vehicular restrictions that I mentioned. The government has used a lot of rhetoric similar to in the United States of patriotism and exceptionalism, urging people, to work for their homeland, No, we can do this, or we show the world how good we are. That's sort of the message that's being used. But those perceptions change depending on your income. Again, if for high and middle income countries, this people make sense, and you see a lot of shaming towards those who leave the house. But then in lower income households, a lot of these might sound nice in theory, but in practice, they cannot stay at home all the time. Especially if you were in the informal employment sector, as I mentioned. Next, please. Last two slides are more an interesting cultural analysis of the discourse and the narrative in the country. So here in the United States, you see a lot of the metaphors used by the government or public health people is, we are at war with this invisible enemy. Healthcare workers are on the front line. There are heroes. That's sort of like the metaphors used to represent this. In Costa Rica, culturally, that does not work. We don't have a military. So the metaphor that has been used now in terms of bringing up, again, that sort of like exceptionalism or patriotism is soccer. So the famous soccer players are in TV ads. Officials from the government talk about, we're only in the halftime of this game. We are winning 1-0, but we still have the half of the game to go. We can still win this game. We did great in the World Cup. We beat rich countries, so we can also beat rich countries in this. And that's a sort of narrative that people are using, or the government are using to bring up these nationalist ideas. The downside of this is, as I mentioned, the large population of Nicaraguan workers in Costa Rica has also brought up a lot of xenophobia and aporaphobia in Costa Rica. So there is already an increased attacks and bad commentary and discussion about reopening borders and how a lot of Costa Ricans feel about foreigners, but particularly Nicaraguans. Another neglected group is Indigenous people. Only about 2.5% of Costa Ricans are Indigenous because they don't live in the main cities. So far, they have not made the news, but they're a particularly vulnerable population that, while they're getting some attention, for example, all the education material from the government is done in 6 different languages other than Spanish. There's not even enough of that. And the last slide, please, just to end on I think an interesting note. There's been a sort of a cult of personality in Costa Rica with the Minister of Health is the guy in the center. He's a young, good-looking guy. He's been very strong about this, and he's gotten quite famous, actually more famous than the president right now. So memes abound about him being dancing with the stars after this. Someone already made a bobblehead figure of the Minister of Health. So I wanted to end on this because I think it's an interesting situation and also shows like the sort of the cultural interaction that people in Costa Rica have with politicians, but particularly with the healthcare politicians, the Minister of Health. Usually in every single administration, the politicians related to health are the ones that are graded higher among population in any poll. So that is showing up here as well. With that, I will end. I think I took a little bit longer than I should have, and we're ready to get questions.
Great. Thank you so much, Jorge. We appreciate your presentation, and I very much enjoyed the thinking about different cultural metaphors and the difference between being at war versus being on a team. So thank you for sharing all of that. So we have about 12 minutes left for our question and answer session. So we have collected the questions in the chat. If you have other questions, go ahead and throw them into the chat function. What we're gonna do, there's lots of questions in there. We won't be able to get through all of them, but with your registration for this webinar, you can use that same logon information to get to the AAA Communities platform. The link is here, but you also received that in your email when you registered for the webinar. And we will take all the questions on here. The ones we don't get to, we'll post them in there. And hopefully if our speakers have time, they can return and kind of answer those. But it's also a way to have ongoing discussion and collaboration in the communities platform. So we're not just ending right here. We can keep having these great conversations.
And Kristen, if I can, we can go a little bit past if you want to.
Okay.
It's up to you.
Yeah, we'll see if our speakers are able to.
Yeah,
That
okay, thanks.
would be great. Let's see, for Suman, one of the questions that came up, and then I actually saw that you had made a note that you're hoping we had a chance to talk to,
Yes,
is
yes,
a few people had actually asked about Ayurvedic practices and using Ayurvedic medicine in a response, and then wondering if that was kind of accepted by everyone, if that was universally kind of being accepted, especially considering maybe there's roots in Hinduism and thinking about Muslim and Christian populations.
Yes, thanks, Christian. Ayurveda is one of these traditional medicinal practice by Indian people long before it started in 100 BC. Now the thing is that in 2014, when the government came, the BJP government came in the parliamentary democracy position in India, then they revived this Ayurveda and they put into the separate ministry. So this ministry known as Ayush. See, the Ayush is one of the ministry. So all these kind of knowledge have the different parts of India, the rural people, the tribal people, the Muslims are also there. They're all of them know the what kind of things specifically for the Ayurveda, the Hindu tradition is there. Basically, they are using the natural resources. By using the natural resources, the remedies for the medicines. But there is a clash between the modern medicines and Ayurveda. No, so Ayurveda, there is a clash. All folks from India, they know very well about what the implications of the Ayurveda. But the thing is that people are trying to get the results more faster. So when I did my work into the forest areas in Orissa, the Orissa state in India, so the tribal people basically they know that the different type of herbs is very important for the curating the malaria from the malaria, but they are never taking these sort of things very rigorously, as because they depend on the chloroquine. So chloroquine give them the better results, quick results, as because they are going into their own day-to-day activities. So Ayurveda is still there. Ayurveda is a long-term tradition. People are accepting the Ayurveda, but in a recessive form, not in a dominant way. So Ayurveda is occurring in the secondary level or the different third degree level of defense mechanism, any sort of health problem in India. But in India, we have now appointed in Bengal, in West Bengal also, we have different medical colleges, and we have also different Ayurveda PG university also. The government has given the opportunity to practice the Ayurveda doctors in different hospitals. So people are coming now a day in order to understand what is the beauty of Ayurveda. So it's the chronic disease is very important for the Ayurveda. So people are knowing these things, but people are knowing these things, but they are first preferred to the allopathic medicines, then going to the Ayurveda. Ayurveda is not the first line of defense for the rural people as a whole. Question.
Thank you so much for giving us elaborating more on this. Jorge, there was some questions for you, thinking of Central America, thinking of Costa Rica and the infection rates being lower. If you were able to maybe give some reflections on why you think they're lower, and you did a great job of kind of discussing the strong primary healthcare system in Costa Rica. I don't know if you can reflect on if that's playing a role, if testing's playing a role.
So in terms of Costa Rica, I mean, it's low in terms of worldwide, but in terms of Latin America, it's high. We're like one of the four with the highest numbers, but the mortality is very low. All the Central American countries, Panama is actually quite high for their population. As I mentioned, the case of Nicaragua is a little bit uncertain. But other countries like Salvador, Honduras, and Guatemala, same as Costa Rica, we did an early lockdown. So the countries early on decided to close borders, for example. The other reason is Costa Rica and Panama have the highest burden in terms of international flights. So in the other countries, they're less exposed to people from abroad coming in. So that was already a level of risk, as opposed to, say, New York, for example, a hub for the entire world. So already that aided in that situation. Also depends, countries that have a bigger rural population, the lower density population allows for a slower progression of the transmission of the disease. So that you can also see that depending on the way the different countries have a majority agrarian population versus cities. And you see it in Costa Rica, where there's two provinces that have almost 80% of all the cases, and then the rural areas have very little. But so early response, early in the case of Costa Rica, early sort of like sending people to do telework when possible. The government itself, it was about 5 days in the first case, and the president ordering the government to do telework. That was very fast. Testing has been good actually in Costa Rica. Is testing people with mild symptoms as well. So it's less restrictive than, say, here in the United States. So of course the absolute number is never as high as here, but in terms of the number of people with symptoms and what percentage of those get tested, it is a bit higher. Another situation has to do with again the preparedness with the healthcare system, organizing beforehand in terms of getting ready to treat those people. And that doesn't mean just having the ICU beds, but it means that the ERs had a set of protocols for receiving patients in there to avoid transmission from one to another. My father was recently in the hospital with pneumonia, non-COVID, he got tested, but he himself told me how strict it was, the going through and getting tested and being isolated from the rest of the hospital. So very strong protocols are there already in place. That seems to be so far what we can think of in terms of the reason for why there isn't that much of a transmission. And I think the general trust of the population with the healthcare system has allowed that, even though we cannot do very strong enforcement because of our legislature, people do follow, for the most part, the regulations.
Great, thank you. It's inspiring to hear, actually hearing like an early response and a trust in the recommendations of people following. Thanks for sharing that. One question for both Jorge and Suman. One of the comments in the chat was discussing the effect of this pandemic that is, a global pandemic is affecting all parts of the world. The question is, do you think that this pandemic will either enhance that concept or sense of global community, or do you think it could decrease it?
You cut off half of the question.
So the question was asking, like, thinking of a global community with this pandemic, do you think the concept of global community, is it going to enhance where we're more united, or do you think that it could decrease it because of the inequalities?
I think, may I talk?
Okay.
Yeah.
Go ahead.
I think it will connect. It will connect the global community, as because in the era of globalization, we have to depend on the different nations in terms of our living in, also after the pandemic is over. So this pandemic creates more understandings, more sharing of knowledge of the, that in Ayurveda, in Indian traditions. So government are trying to disperse this knowledge in the worldwide. So how the government are also trying to see the different cultural backgrounds, how they are perceiving these Indian Ayurveda in the context of their own development, own welfare. So in my opinion, time will come when this pandemic is over, but the art will get the new kind of corporations, new kind of world surfaces. So that will come definitely. There is a positive thinking from my mind. So
yeah, great.
I think I'm on the fence a little bit. So on the one side, I do see a lot of cooperation happening. Again, our president a couple weeks ago actually sent a proposal to the WHO that the Secretary General actually took, and he is using it. And the proposal was that all members of the WHO sign an agreement to openly share the results of all research that has to do with COVID-19. And sort of an open source to create a pool of knowledge to do this. So I think in terms of international cooperation, this will help. And also, strengthening systems of sharing information, because as we know, otherwise the spread of a disease like this cannot be controlled if we have limited access to data. On the more population side, I think as an anthropologist, my worry is the narrative that many countries, United States, Costa Rica, are putting a lot of importance on this idea of nationalism, of we're exceptional, of sort of like we're going to be the best at controlling this disease, and then that can create an issue of those who don't do as well, we don't like them. So there is this double-edged sword of appealing to people's patriotism to control this disease, that then can delve into issues of xenophobia or agoraphobia or different ways of not wanting to engage with the people of different nationalities. So that's why I say I'm a little bit on the fence as to what will happen after this.
Yeah, it'll be. We'll see. We'll see where we do progress. I want to.
Christian.
Yes.
Yes. May I give some answer for the advanced questions as given by Dr. Polanco, International Development and Social Justice and Human Rights?
Yes.
Can you give me the permissions to tell something?
Yes. Go ahead.
Okay. Thank you. So she put some questions that number one, where you work, as I propose, I have told that I am working in India, in the eastern part of India as a undergraduate teachers and also researchers in medical and biocultural anthropology. So next is a local community response to COVID, as I presented my presentations. So third is the external interventions. Yes, we have the national level government interventions right now, and the Niti Aayog, the Planning Commission of India, the Secretary of the Planning Commission of India, he wrote one letter to 92,000 of NGOs in India to come and to work together in the ground level, in the micro level, in the rural level, into the different basic level, provide them the food, provide them a different type of equipment for protecting them from COVID-19. So the Gunj, one of the NGOs came first. The Gunj is a national-based NGOs. They are working at the very ground level. So still now, the contradiction with the local practice with examples, as I have put some of the examples from the tribal community. So far, the data I have collected from through my phone. So the contradictions, yes, contradictions. There is no solid contradictions still now emerged. So maybe the contradiction will come when if the COVID-19 cases embedded into the rural and remote populations. So we should look into this matter very meticulously as a student of anthropology as a whole. Thanks, Christian.
All right, thank you. We do have a few, we can extend a bit, but before we do maybe keep going, I wanted to pause here and move to the next slide. Just moving forward, I think there is, that's not a save the date for the 16th because that's today, but I think there is going to be an economic inequality webinar coming up. So keep your eye out on the AAA's website for that. All the webinars are recorded and then available on there, and I will also post this recording when it's available. I'll post it to the community's platform. There also is an Open Anthropology, a new volume that members from our group have been working on that just came out. And the Open Anthropology, it takes articles that have been published within AnthroSource and is able to open them up to take the paywalls down. And so this article, this edition, the Pandemic Perspectives Responding to COVID-19, is wrapping in what we already know and what's already been published on pandemics and how to respond. So please check out that resource also. I will take all these links and also put them on the community's platform, so you'll have them even outside the slides.
And Kristen, if I could, one thing, we have until about 2:45 our time, so about 10 more minutes.
Perfect.
Thanks.
Thank you, Jeff. So the next slide. So just in case people have to jump off now, and then we'll continue on for 10 minutes, but I did want to especially say thank you to each of our speakers, to Isaac, even though he couldn't join us live, we appreciate him taking the time to record, and to Suman and Jorge for the wonderful presentations and giving us an idea of how people are thinking of COVID-19 and responding in your different areas. And a special thanks to everybody at the American Anthropological Association, Ed and Jeff and Scott and Gabriel, and there's Nell and I think Anthony were helping with the closed captioning, and that was a wonderful extra resource to have. So thank you so much for putting all this together for us. We can just leave it on that slide, and then we do have about 10 more minutes for questions and discussing some questions. Suman, there was one question on there that I was curious about if you were able to respond, and the question was, in the past, smallpox and measles in India, that some have associated that with receiving mata, and a question of, is there any conversations that you're hearing of people of having a similar kind of construction of COVID-19 in that way?
Yes, you were right, Christian, that that the Bengali people, as I am from the native people, from Bengali ethnic groups, so we have some deep connections with the measles and this basically the measles with the mata, so the mothers. So still now the people are not able to conceptualize what kind of things are coming, as because the symptom, the COVID-19 cases, the flu and fevers, all these things, the flu and fevers and cough and cold is very common in this part of the world. So they are not going to doctors. As you know that in medical anthropology, there's a separate concept of disease, illness and sickness, no? So people are not even going for these things. But let us see what will happen in the populations if that is very pandemic in nature in the local population as a whole. So obviously people are they will try to connect some of the deities we have to link this particular COVID-19. I think so. So yes, obviously there's a possibility that people will try to link with our mother goddesses with this particular disease to try to impart for the particular things. No?
Yeah.
Thank you.
All right, thank you.
Another question, is it possible to give another answer regarding the untouchability?
Yes. Yes, go ahead.
I would like, I would like to share one of my experiences. So one of my experiences, like when I doing the work around the tribal areas in the central part of India. So I visited one village where the 5 pregnant mothers were staying. No, so after that day when I visited the ICDS, we have the different type of awareness and the program in the micro level, like ICDS, Anganwadi worker. They are the facilitator to the pregnant mother for money, for food and all these things. Then I just asked that particular lady that whether you visited that particular village, they have the 5 pregnant mothers. And she replied me that there is no pregnant mother. So I said, I've been visited the particular village. Why you are not going? And I am not going because they are not untouchable groups. So this is the basic things, you know. So that's why I'm telling that the habits and attitudes of the ARHE peoples who are working in the ground level is very, very important in Indian context regarding the untouchability. whether they are going to the macro level, each and every households and every persons. So I repetitively, I face this sort of discriminations and untouchability throughout my career up to the from 2003 to 2020. Yes, it's a deep embedded concept and still exists, and it will affect the cohesiveness of the COVID-19 cases in future time in India. We should look into this matter. Thanks.
Thank you.
Good question.
Yes, thank you. Thank you for elaborating on the disparities that we're seeing. We're, you know, disparities of lots of different levels, and both you and Jorge even brought up education and disparities of distant learning that are going to continue and will feel reverberations. And we're certainly seeing here in the US, COVID-19 having a very clear way of highlighting what disparities are already there. So Jorge, there's a question, if you're still on, I don't know if you had to jump off or not. Are you still here?
I'm here.
Okay, there's a question about Chinese businessmen investing quite a lot in Costa Rica. I'm wondering if there's been any pushback on foreign investment and the presence in Costa Rica because of the pandemic.
I did not know that part about the actual like investment part. I know in general the common the expressions of xenophobia have been there, just like here you see it in. I do a lot of digital anthropology, so looking at memes and message boards and what people put on different social media. But for example, I know that a lot of the masks and equipment does come from China. So the masks that are being sold there, either in the healthcare system, but also people for regular citizens, those do come from China. In general, I would say, I'm looking at the digital anthropology part, while the narrative of it being, you know, a virus from China, etc., is not as strong as I hear. And I think it also has to do with the fact that as nations, we are not engaged in any sort of, you know, geopolitical fight with China. So that has, I think has led us to not be as to have that much animosity. But I would not say it's not there on the popular level. On the governmental level, there has not been any issue or any comment from the government. If anything, the time that the officials have mentioned on TV, it has been about telling people, hey, we're calling this COVID-19, not anything else. We don't do that kind of stuff. So that's been it. So I think for the general people, but definitely not the government there, and definitely not sanctioning trade, because we are buying a lot of equipment there.
Yeah. All right, great. That's good to hear, at least from the top, hearing a pushback on names and xenophobia ideas around that. So one question that could be for both of you, and this might be our last one we can do, and then we'll put the rest up on the community's platform. But one of the questions that I would just be curious on each of you kind of reflecting from different areas is the extent to public health measures and directives, and if it's being used to kind of mask maybe other government failings in a way that if there's, you know, other failings of people of it spreading in terms of lack of testing or lack of healthcare providers, if the measures that are being put out there could be flipped to use of blaming the victim then if they do become infected.
I don't know if someone wants to go first, right? Back home, what did happen is early, before this happened, there was the government, the current administration had been losing favor. So the popularity levels have dropped quite a bit since when they won the election a couple of years ago. So the current management has helped them, you know, gain more momentum. But I think those numbers are happening all over the world. It's sort of like a natural effect of it. In terms of it used to disguise lack of other things, I don't think so, because they've actually been very transparent about that. for example, every day, that the graph I gave you at the beginning, it's the official one from the government. They put it out every day, and it includes the number of tests done and the number of tests that have came out negative. So they do give the total number of tests every day and how they're done. So I think it has helped in terms of more of help the government popularity-wise in general, but in terms of the trying to hide specific areas of the management of the pandemic, at least not that I sort of have identified. If anything, it has done. It has changed a little bit the relationship with it, though. The minister, you know, sometimes you see him actually like lecturing people. He gets very angry sometimes when people don't do stuff, and that's a sort of like interesting thing to see. That's not common before. But yeah, that's what my take is so far.
Okay.
Yes. In India, yeah. Can you hear me?
Yes.
In India, yes. There's a question regarding the trust and responses. So that in a few days back, when the government of West Bengal, one of the state of India, is trying to build some isolation ward in the northern part of Bengal. Then the local people came around and they shouted for to stop this thing, doing the isolation ward in the near the villages. So it is a great challenge for the government also. So they have to build a clear strategies, clear management, how to tackle the pandemic, where the 70% populations are from the rural and the remote one. So this is very important for the point of people understanding. So how they manage, they keep taking this as important for anthropological perspectives too. So this is a great challenge for the India as a whole. Right. Thanks. Christian.
All right, great. Thank you. Well, we are out of time, but thank you so much for spending this almost close to 2 hours with us. We appreciate you taking time out of your busy days. We will over the next, it'll probably take 2 days, maybe 3 days to get all the questions put onto the community's platform, but we'll be working in that direction. And as soon as the video is available, I'll also put that on the platform. So that way anyone who registered but then wasn't able to jump on can have a copy of it.
Thank you, everyone.
Okay. Thank you.
Bye. See you. Thanks, Christian.
Thanks, everyone. Thanks, Kristen.
Thanks, Livo, Jeff, Scott, Nanki, and it's give me the opportunity to share. This is the first webinar conference in my life, so thank you for that.
Yeah, it's entirely our pleasure.
See you next time.
Okay.
Thank you. Bye.
Thank you.